Hi, everyone. Good evening. Thank you so much for joining us tonight at our Let's Make Sense of Primary Sense webinar run by Brisbane North PHN. My name is Claudia Savage and I'm the project coordinator of the Primary Sense transition. The purpose of the webinar is to inform, educate, and make sense of primary sense. Understanding that the tool is still in its infancy, we want to help integrate this into your daily practice and it not be another thing that you have to do on your to-do list. We are joined to my right here by our GP panel, and they're here to provide their insights and experience with the usage of the tool in practice. Thanks. So before we get started, I'd like to offer an acknowledgement. We acknowledge the traditional custodians of the land in which we acknowledge the waterways, the land, the sky, and all of those who inhabit this country. We acknowledge their ancestors and elders and recognise those who continue to protect and promote Aboriginal and Torres Strait Islander culture. We acknowledge the past and we stand together for our future. Thanks, Amy. So just to start off with, a little bit of housekeeping. We'll have time at the end for questions. So if you'd like to add them into the Q&A section of the chat that you can see up the top of your screen, and we'll answer them at the end. If they do not get answered, or we are not able to answer them due to it not being our area of expertise, I will direct it to an expert in that area and send the responses to everyone. Or if they don't get answered, we will have them recorded and I will send them out in the form of a FAQ resource at the end of this webinar. This webinar will go for 60 minutes and it is being recorded. It may be used as a training resource for practices or internally for PHN staff. Furthermore, those who are not able to attend that registered will be able to access the recording. We'll be sending that out. Once this webinar has finished, you will get a notification of an evaluation survey, and that will appear on your screen, and we would greatly appreciate your insight and feedback as to how you found this webinar. Our slides and a certificate of attendance will be sent to you at the end as well for your quick log of your CPD points. And lastly, if there are any issues with sound throughout the webinar, please just pop it in the chat. As we have a few different microphones throughout the room. So just let us know. Thank you so much. Next slide, thank you. So having a look at the agenda for tonight, we're going to be going through Meet the PHN team and the GP panel, the why of primary sense. So having a look at PIPQI, CQI, and CPD points. We'll be deep diving into primary sense itself with an introduction, having a look at the ACG system, prompts and alerts, and the reports. And lastly, we'll end with a Q&A with our GP panel. Thanks, Amy. So, meeting the quality improvement and development team. So as you can see on the left-hand side, I'm there. My name is Claudia and I'm the Primary Sense Transition Project Coordinator. On the right-hand side, we have our Quality Improvement and Development Engagement Officers. These team members currently support CQI and development and primary sense training for over 340 practices across our region. To increase capacity, we have just added a new team member to join the team 2 weeks ago, and we actually have a new team member starting next week, which is really exciting. So in our team, we have Joe, Kim, and Leanne, and joining us tonight as presenters, we have Marisol and Michelle. Thanks, Amy. So I'll introduce you to our panel tonight. We have Dr. James Martin. James is a full-time GP at a small family-owned practice at Sandstone Point. He has been a GPLO since 2014. Then we have Carolyn Clancy. Carolyn has been a GP for 15 years and works at a practice in Marumba Downs. She joined the GPLO program in 2022, focusing on mental health. Then we have Dr. Shristi Dutta. Shristi has been a GP for over a decade and worked as a doctor across 3 continents. Since moving back to Brisbane in 2014, she's been involved with medical education and worked as a GPLO since 2017. And lastly, we have Dr. Meg Hans, and Meg has been a GP for over 25 years in a practice in Ashgrove, and she has been a GPLO since 2013. So thank you so much for joining us. We're so appreciative. Wonderful, thanks, Amy. So moving on to the why of primary sense with PIP-QI, CQI, and RACGP CPD points.
So your PIP-QI incentive, that was first introduced to practices in August 2019. To be compliant with that particular PIP, practices are asked to share their de-identified data with PHNs and also to do quality improvement activities. We're now calling them CQI, continuous quality improvement activities. The tool will support these measures, the 10 PIP-QI improvement measures. They're not a mandatory measure, but they're certainly there if you want to work towards them. A practice may focus their CQI activities on any other areas also that meets their needs of their practice population. If I can have the next slide, please. We hope to integrate the primary sense tool and support GPs with their now RACGP CPD points. Each calendar year, you're expected to record 50 hours of CPD across different activity types. And some of these required activity types can be mini individual audits, they can be clinical audits. You are expected of a minimum of doing educational activities of 12.5 hours. You're reviewing your performance and measuring your outcomes, again, a minimum of 5 for each of those, and you can do up to 25. There is an additional any activity type that you're using your activities, your performance reviews and measuring outcomes for 12.5 hours, bringing to a total of 50 hours. We'll talk a little bit later on in the evening of how you do that as particular audits with some of the experiences of the GP panel here tonight. Next slide.
So primary sense and introduction. Thanks, Amy. So primary sense is a population health management, clinical decision support and data extraction tool. It was originally designed by GPs, data experts and researchers. Primary sense extracts de-identified general practice data and uses evidence-based algorithms to provide GPs with real-time medication alerts, reports, and patient care prompts. It also provides general practices and our primary health networks that are transitioning with on-demand reporting to help with population management. At the center, as you can see with the primary sense logo, the patient is at the center supported by their GP. This logo has been constructed to identify and really highlight the 6 main points of primary sense, which is data extraction, data analysis, decision assist, care planning, care optimization, and care review. All of these aspects we will be discussing across the webinar tonight. Thanks, Amy. So having a look at the benefits of primary sense, specifically to you who are online and joining us tonight, it is highly intuitive and easy to use software providing real-time data. It has easier identification of high-risk patients with complex needs with the Johns Hopkins ACG Adjusted Clinical Groups tool. It facilitates self-directed measuring outcomes with RACGP points, increased opportunity for integrated quality improvement during your GP-funded time, so in practice, faster distribution of targeted reports supporting a response to community health and emergency events, increased practice revenue through automated identification of MBS claimable items and care plans, more consistent provision and application of evidence-based decision support through prompts such as missing interventions on opening a patient record, and lastly, medication safety alerts at the point of prescribing. So the primary sense ACG Adjusted Clinical System tool. Thanks, Amy. And from here on out, I will be referring to the ACG system by its acronym. So the Johns Hopkins ACG tool is a world-leading health population analytics software, which stratifies patients into different bands or levels of complexity. There are currently 5 levels, and the complexity levels reflect the hospitalization risk and current care needs of the patient. Ranging from 0 to 5, level 0 indicates a low level of complexity with no known risk or poor health outcomes, while level 5 is the highest complexity level with patients of a level 5 typically have significant multi-morbidity and polypharmaceutical aspects to their health and are at greater risk of poor health outcomes. So just a little note with that, the profile is based on visits, notes, and it relies on clinical coding in both MD and best practice. Included in this slide is an excerpt in which you will see in all of your reports within Primary Sense, and it just gives a nice understanding of the different classifications of the complexity levels. Thanks, Amy.
So Primary Sense GP prompts and alerts. Currently GPs are receiving prompts and alerts, and we are in a stage where they're actually developing prompts for practice nurses. We are really interested to get feedback into what would be of interest to the nurses. So watch this space, but currently these prompts are solely for GPs at the time. Here are a list of the prompts that are currently available within the tool, and to the right you'll actually see an example of what that looks like. We're just going to show a very short video now so you can actually see how the prompts interact with your clinical software.
This is the demonstration of a GP prompt, as a GP would receive a prompt in their day-to-day practice. The patient is selected and the record is opened. Within a couple of seconds, prompt appears. The prompt outlines up to 3 elements that the GP should wish to consider. Here we can see it's for John Andrews. Within the prompts, there's more information. Click on that reveals any other results that got the prompt to trigger. We also provide links out, so the GP can click on the link and go to the evidence base without leaving their screen. The prompts have selections, and the GP can read the information and decide what action to take. Here the GP is going to select next time. GP can then move down to the next prompt item and select a choice there as well. They can also write comments. This helps us with auditing. Prompts only stay up for 3 minutes. That's because we don't want the GP to get confused about which prompt is up for which patient, but they can click give me more time to reset it. They also include some information from Johns Hopkins to perhaps the risk factors. At the end of the shift, the GP can go back into the history and retrieve any of the prompts that were triggered. And again, they can change their action at this point if they wish to. If they do click on wrong, we do ask them to submit a comment. This helps us to correct the system if we've missed something or there's an error in the logic. These are the prompts that are available to the GP. They can opt in and out of the prompt. Here the GP is choosing to opt back into this one. And the next patient that comes in that meets that criteria will trigger.
Here are the list of the medication alerts that are currently available to the GPs. Again, to your right, you'll see an example of what that looks like, and you'll note the little tabs at the bottom. The GP will actually need to indicate one of those appropriate actions for that alert to disappear. Again, we'll just watch a really quick video on how this tool engages with your clinical software.
This is a Primary Sense medication safety alert. Here we can see the alerts available to the GP. And we can see the GP has opted out of one of them and chooses to opt back in. The GP will now receive alerts for this scenario. So the GP selects the medication In this case, it is an antiplatelet therapy. Continues to prescribe. Medication alert appears. We can see here it's for Frank Potts, and it has some information about why the alert is triggered. We can see here that Frank has got a history of peptic disease. GP can click on a reference and get more information about why this alert triggered. GP can write comments, which helps us with auditing. And can select one of the options. Anything but remind me next time, we'll turn it off for 12 months. At the end of the shift, the GP can go back in, check their selections, and refresh themselves on why they've made that choice.
Now, speaking to primary sense reports, Amy, if you would, please. We'll do a short video and then come back to talk.
This is the primary sense reports that are available. Click on the tile and all the reports are available. You have patient lists, aggregate reports, and PQI reports. You can filter here to get to the reports that you want. And click on the report, returns it to the practice within a minute or two. There's more information in the drop-down menus. This helps the practice use the report without the need for additional training. Reports follow a similar format. There'll be information about the specifics in the table. And they also include the Johns Hopkins risk stratification score, which helps the practice prioritise. We include the date of the last visit and existing appointment when there is one. The reports can be searched to create a list, either with patients or for the GP. Here we're looking at Frank Potts, who's got a history of chronic disease, who's had smoking cessation tried, and has had recent pneumothorax. We can go and check this Frank's record. Here we can see he was tried on nicotine lozenges. He's got a history of chronic bronchitis and diabetes, and he had his pneumothorax in 2021. So we can see there. To look at another patient, we may decide that this patient doesn't really need to be on this report for whatever reason, and the practice staff can remove the patient from the report. So the next time the report runs, the patient will review. The reports can be exported to Excel and do save on the GP or the practice manager's testing.
The reports in primary sense, as you see, are limited at this present stage. Watch this space. We're encouraging feedback to what reports you might like to see and then get developed later on. They're easy to use. You identify what particular cohort of patients you might want to work with. You click on the report and it will populate. At present time, we've got one to demonstrate, and that's your accreditation, that's your percentage compliance. And if you could. What we were doing beforehand when we were using a previous extraction tool, the PenCat, we were giving you quarterly data reports on the de-identified data you shared. The first page included your accreditation measures, and this one, and often you would have to wait a wee while for that to come back to you to talk to. This is live data. You'll be able to look at this information as frequently as you would like so that you can benchmark yourselves against those measures. You can look at those particular measures and work towards small quality improvement activities. Next slide. Health assessments is another one. It's looking at your patient cohort. if we go to the next slide, it will show you that, and apologies, it's a screenshot. It's broken into 3 areas. Your first patient cohorts, your 40 to 49, including the 45 to 49. After that, there is your Aboriginal and Torres Strait Islanders who are due for health assessments. And lastly, your over 75s. PIP-QI, there's 3 reports at the moment. One will be your 10 measures, and again, that's your percentage compliance. Another is your patients missing with the PIP-QI. And the one that we've circled and we'll quickly have a look at is, and practices are really appreciating this one, is looking at patients that are booked in the next 2 weeks with an appointment to see your doctors and who might be missing those PIP-QI measures. So you will be able to opportunistically capture that missing information, and the doctors are here later on to talk to that. And that's just a demonstration of what that report might look like. Appreciating its demo data, so we didn't have any patients to show. Navigating the primary sense on desktop. So the little icon on the left-hand side up top, as Claudia mentioned earlier, if that will sit usually on the bottom of your toolbar. If you click on it, it will expand to a sidebar. And if you choose to go to the settings down the bottom of that sidebar by right-clicking, it will bring up that middle illustration of a small directory. In that, you can click on the primary sense performance. They also have your function keys. The primary sense performance is a really good quick report to see if the tool's working and it's refreshing as frequently as they say, possibly 5 minutes. I think it's mentioned for a third every minute there. You'll be able to see a snapshot of your patient cohorts and the RCG patient bandings. In this instance, it's mentioned that there's 11 patients based and banded as your most complex with comorbidities. It will also at the bottom identify medications checked for alerts or GPs who may be getting an alert. So it's a good indicator of how the tool is being used in practice. Also at that directory, just a little bit further down, you can see there's websites. If you click onto that, it will take you straight to the Primary Sense website, where there's more little videos to be seen and shared and some resources. Thank you. Next one.
We have had instances where you open Primary Sense and you'll actually notice that the first 3 tiles are either orange or red. Just to give you a bit of context, if your tiles are showing red, that means that the software has stored for the last 24 hours and that your prompts, alerts and reports may not be current. If the icons are red, then that means it's actually stopped and it's not working at all. You will get this little error message that's popped up there on the screen. We will provide a troubleshooting guide at the end with all the resources at the end of this webinar, just to help you navigate that. However, if that doesn't suffice in practice, please know you can call upon your quality improvement development officers and we'd be more than happy to help. Thanks.
So having a look at the feedback mechanism within Primary Sense. Thanks. So as we've discussed, you have your icon at the bottom of your toolbar. If you're wanting to provide feedback on the reports, the prompts, or the alerts within Primary Sense, all you need to do is click on one of those 3 icons, and that will bring you up to this tab of the second image on the right. There's a few options on there. However, this is a great opportunity to provide feedback within the tool as you're using it. And then if you click on provide feedback, it comes up with this third image. So just note, importantly, that the subject, the name, and the email address are optional. So if you would like to keep your feedback anonymous, you are more than welcome to. What you can do in this box is at the point of when you're thinking of that feedback, you can quickly right-click, put your information into this box, and it will actually submit it to the national team. What happens then is all the feedback is being collated, and your feedback is so valued, it actually helps to create the roadmap and enhancements of the tool as we look at trends of where the feedback is coming from GPs and users of Primary Sense. So if there is feedback that you do have, I highly recommend you use the function inside the tool. Or if you'd like to provide feedback in another way, you can certainly do it through practice support or via your QIND officer for your practice as well. Thanks. So now what we're going to do is we're going to move on to the GP panel and listen to their insight and their experience thus far of using the tool. So we can start with prompts, if you'd like, Megan James.
I'm happy to start. Hi, everybody. Yeah, I'm as a GP, I suppose prompts were the first time I kind of saw Primary Sense happening in front of me. Suddenly there's a prompt in my face, and it's okay. This is Primary Sense then, and there was a lot of them, and too many for me. I found them rather overwhelming. It was time of year we were just starting to do flu vaccines, and a lot of them were telling me my patients were due flu vaccines, which I wouldn't be getting around to giving them. So my advice to anyone who's found themselves in that position would be to dial down to some more manageable prompts and stick with the ones that you like to be able to action that are more appropriate for your cohort and season or whatever it turns out to be. I also had a few issues. I think there was a demonstration of the microalbumin missing prompt. And I found that popped up 1 or 2 times when my patients had very recently had a microalbumin done. So if you've encountered any problems like that, my understanding is that they are being fixed, so don't give up on them. And I think things like that are being ironed out through feedback and other mechanisms. So by starting for myself, starting with a small number of prompts and then gradually looking to extend those is how I incorporated them into my practice.
Whereas Meg, you might speak to your experience.
Sure. Hi, everyone. I was the same as James. We had it in our practice showing up before any of us had training. So I really just let them disappear in the 3 minutes. When I first had it, I didn't do anything. And gradually I've started to do some actions, and I just started really simply with doing next time. I'd hit next time on pretty much everything. So, but I think even when you do that, you've at least seen something and it's helping you reflect about what you're doing for your patient. And then as gradually I've started to do more things. So I've been using some of the agree but override. I haven't done any wrong ones yet, or not for me, or maybe if I've opened a patient's record when I'm just checking another GP's results on a day they're not there, I might say that one's not right for me. And today I put in my first comment to send some feedback. So I'm just gradually doing more with it. So I think it's quite handy, and I think all of the features of it, I appreciate that practices need to meet certain requirements for accreditation, and they may need to meet certain requirements for their PQI incentive payments. But from my point of view, it's an opportunity to reflect about how you're looking after your patients. And it might be that you see something, like microalbumin or a medication alert or a flu vaccine. It makes you not just think about that one thing, but think in general about, am I doing everything for this patient that they need for their health? I found it good from that point of view to reflect and to think, are we giving optimal care for our patients?
If we wanted to talk to the audits, or will we talk to reports first? Talk to reports first. So I think Caroline and James, you've been proactive in looking at your PIP-QI reports with missing demographics, with the patients coming in the next 2 weeks.
Yeah. I mean, this was, as I kind of indicated when talking about prompts, Primary Sense seemed quite overwhelming. It's enormous potential, and seemed to be trying to do everything at once, and I couldn't fit it into my standard sort of workflows. And so I was sort of thinking, well, how are we going to use this thing? I could do so much, but you know, how do we make it do a manageable amount of what we want? And the way that we've started to tackle that at the practice is to give a nurse an hour or so a week, supported by the primary care QI team and Marisol and Michelle, and they've been able to generate a report on patients who are booked to attend the practice in the near future, and that timeframe can be adjusted, that are missing one of their QI data points, to enable us to intervene and collect that information and, you know, improve the data accuracy in the practice. So the nurse generates the report. She puts a little flag next to the patient's appointment and also provides us with a list. We've decided to try and improve our number of patients or percentage of patients who have their BMI recorded. And so she'll print out the list of just those that have that missing, ordered by the doctor. So I had 5 or 6, and it also flagged where there might be other data points missing in those files that we could also look at. So for me, it just brought it right down to a manageable amount. You know, I can do that. Get a patient, stick them on the scales or under the measure before they even sit down, put that in and start to kind of build our practice data quality that way.
Yeah, I agree. I think it's making it to a manageable chunk. So we've been looking at our practice at what's our most missing, the accreditation section that needs the most improvement for us, and sort of focusing on that. But also, you know, as you've identified, like getting a list of the patients who are coming in, and then, you know, depending on what the data point is, most of them are appropriate for the GP or sometimes a nurse to ask the patient about. But for example, if ethnicity is missing, that might mean the reception can ask the patient, you know, when they're checking in, and that can sort of improve our percentage points there for the practice. So it's, yeah, just little steps to achieve overall improvement for our practice and our patients.
It's just one other thing I wanted to mention about reports, because I knew I'd be here tonight, and because I'm interested, I thought I'd try some out nice and early, and they didn't work. So that has, I think, been corrected. I've been back in, and they are working. So if you found problems early on with the reports, do try them again, because they seem to be up and running now, and given the data they should be.
I've also been playing with the reports today, and I've tried a fair few of them out. And one of the ones that I found quite handy was the pregnancy vaccinations one. It lets you know whether your pregnant patients are up to date with their influenza or their pertussis vaccinations. And it, you know, when I was mentioning before about how it opens your eyes to other things you may not be up to date with in a patient's chart, that I had 2 patients come up, for example, and one patient had agreed to have pertussis, but they declined the influenza. So, you know, I could make, you know, override that one with the influenza when the patient had declined. And then I discovered another patient on the list who in fact had a miscarriage, and that meant I'd, you know, just hadn't been up to date with, you know, documenting the end of the pregnancy for that patient. So it just alerts you to do some other things and improve how your records are.
Thank you. If we want to talk, as I alluded to earlier in the evening, it's a good tool that doctors may want to use to support any of their mini audits or clinical audits. Shristi is happy to share of what her experience or thoughts are going forward using the tool.
Thank you for having me here. I think just kind of highlighting that some of the people that are attending might be very familiar with clinical audit tools like NCS, which was previously available. So not speaking, not trying to teach you the here, but just that a different tool allows you a few different set of advantages. So big difference is every clinician can have it available to them on their own desktop. It is real-time information, unlike having to run reports previously with NCS. I thought I'd kind of give you a bit of a framework as well, that ideally, as James has already spoken to, that if involving the entire practice as a practice team to pick up a quality improvement activity is the best way of doing it. That means the GPs will require support from the other members of the team to do it as well, and you've exemplified that really well, James. But equally, if you are a GP that has a particular area of interest, then the few that have come up already in the videos could be chronic lung disease, asthma, diabetes. You could decide to create an audit for yourself. It allows you to customize the search so you have an initial patient list to use for the audit. So have a think about what's the most efficient way of doing it for your practice, your patient cohort, and for yourself. But I think sometimes when we look at these things, we tend to complicate it. So have a look at the tool, have a play with it. I should add, I had a play and got a bit disappointed with some things and walked away, but then I asked these guys to help me out and have another go. And I picked an unusual one. I picked hemochromatosis to consider auditing because I was annoyed by how many prompts I was getting. So I've got a patient list of the ones where the hemochromatosis prompt is coming up, and I'm the usual GP, and that's given me the first patient list. And RACGP makes it simple because you can use the evidence within primary sense as your standards. You can have a patient list, put together the data, and that's effectively your mini audit for this year done. And next year you could add things to it in the following year as well, and you wouldn't have to go and reinvent the wheel each year. So my suggestion is to try the tool, to have a look at the existing RACGP audit pro formas and templates, and consider whether it's a practice activity or an individual GP activity, and just get going.
That's great feedback, James.
Can I just say, that does sound like the way to go. If you are generating reports yourself, I found that they're quite large reports with a lot of patients on, and it's not easy to refine them down to the specific area you might be looking at within the report. So talk to the engagement team, like I did, or talk to people in the practice who are doing this, like the nurse in our case, and you can export the report into Excel and make a lot more modifications and refinements to get the manageable amount of data that you want for those. Otherwise, it does seem it is a bit much, and there's only a certain amount of refining you can do within the tool itself, I think.
That's a great feedback.
I was just going to say that, like everybody else, it seemed quite daunting at first. And yeah, having a vision with you guys was very helpful, but also the website has some really good tutorials. You can just, they're not very long, but just sort of watch them. If you can watch them on your computer while you're at work and then play around with the tool at the same time, just doing it while you're reading, watching it is just so much more helpful than hearing about it. So yeah, if you can just set aside a few minutes to do that when you're having a go at reports and things, it really is very valuable. And yeah, having the team come out was really improved a lot of things going wrong for me. So you can always contact the team.
And in terms of timing, I suppose if you had turned off your influenza prompt at the start of the season, maybe end of July, beginning of August is when you turn it back on, and check how many of your COPD asthma patients have still snuck away. Because they're the tail end of influenza that we tend to get in Brisbane at the end of August, beginning of September. So a lot of customizable data that you can use in many different ways.
Thank you. You've been mighty sharing your experiences, and keep going. We hand back to Claudia.
Certainly. So I just throw to the chat to ask some of the questions of you guys. A question was, how can you do population demographics on primary sense? And if you guys can't answer it, and then Michelle and Marisol can, just whoever can answer, if they can, let me know.
If you can go to the report slide, maybe.
I've seen where it is. I have to say I haven't tried it yet, but I think there's a way to look at your own practice population, and there's a way to look at PHN
practice
data. Yeah.
probably those questions might be easier to answer if your QI&D person did come out or at least contacted you and walked you through it via the phone or. But there are processes, as Meg alluded to, there is the practice PHN table graphs. They're not ways at the moment in those particular reports that you can identify patients. The tool is in its infancy, that's the best way I describe it. It's limited to what it does have just now, but it's certainly going to grow. And that's where we want your feedback to how we can support you with this tool going forward.
How does this differ from the medication alerts and preventative health notices that are already generated specifically, say, in best practice?
So best practice has a few built-in health prevention prompts. One of the key differences that I've discovered having chatted to the lovely ladies here is that in the past, when I've tried to look at let's say influenza vaccination, if you tick the box in best practice to say you don't want that to be that prompt to be displayed in the top where the green prompts come up in best practice, it will effectively just remove it. So you'll never get prompted. Whereas with primary sense, if the influenza vaccination prompts coming up, you can actually action it, but it resets in a 12-month calendar cycle, which means next time around when you're having the conversation at the right time of the year, it will still come up. So there is a point of difference compared to best practice. And it's once we have more prompts available, it would apply in the same way to the others as well. Medication alerts, I have to say, are very specific, the ones that are built in. Medication alerts that come in, certainly the ones I've seen in at the moment are really quite red flag type things that would prompt you to have a think about whether you proceed.
Yeah, I've seen some very useful alerts that have come through and some that haven't necessarily aligned with the guidelines that I'd be following, but I don't get alerts in best practice in that way. And
I think the alerts that the person who's asked the question is referring to is when you prescribe something new, the interactions come up.
Yeah.
They're not really individualized to the patient, they're just built within best practice to prompt you about interactions with other medications, and occasionally with the pregnant patients, they will describe the category under which their drug falls.
whereas these ones will look for a potential problem, even if you're not prescribing that particular drug on that day.
Fantastic, thank you so much. There was a question that there, it has been noted that there are excessive prompts to, and forgive me, microalbumin. It does not recognize, or have you found it that it recognizes MCNSs with no proteinuria?
I think it's just looking for microalbumins and not looking at MCNSs, but that's a guess based on what I've seen.
So we can follow that up.
Certainly, that's something that we can follow up. And this would probably be a question for yourself, Michelle and Marisol. If a patient visits another practice, then a prompt may not be accurate.
Appreciating that the tool works within your clinical systems and your billing systems, so it won't be able to identify something that's happening outside of your practice patient data.
But if you're aware that something has happened at another practice and that information is put into your clinical software, then the next time that is run in the background or a report is run, that will then capture that information for that patient. So it's just about managing your software and the data that you're inputting into it.
I guess a good example of how that happens easily now in best practice. So best practice can link with the Australian Immunisation Register, so you can look up someone's vaccine history. I'm sure many people online know that. And you can then save that information into your own immunisation record, and then that would be taken into account when Primary Sense is checking through your immunisations.
Wonderful, thank you. Another question, and this will actually be directed at Pete. So we've got Pete Boffey here, he's our data governance custodian here at the PHN. So in other countries, these tools have been used to award practices for achieving targets, i.e. 90% of vaccinations in pediatric populations, and actually incentivizes practice financially. What evidence is there that this will not become coercive control via income control?
Thank you for the question and welcome everyone. The biggest point to make around this is we've actually been very specific in the agreements and the license agreements that it is an excluded purpose. And it states in there that any performance benchmarking or financial audit undertaken by a Commonwealth or state government agency or any other funding body without the express permission of the practice on each occasion is forbidden under the agreement. So that's probably the best way to respond to that.
Fantastic, thank you so much. So there are all the questions in the chat. Amy, are we able to go to the next slide and we'll answer the questions that have been pre-submitted?
Okay, just to simplify that first question, so for the due influenza vaccination prompt, does it search the file for vaccinations given in other locations? So we did just touch on that before. It doesn't look at AIR or obviously any other practice data. It will only work on your clinical software. So again, if it is recognised that your patient has received that in another practice, updating your system will then rectify that prompt or report within your practice.
The second question is very similar. Again, it will only look at your patient clinical and billing system in practice. It won't go outside and be able to access other practices or Medicare's data. There is a suggestion in this instance, if you're using a patient's My Health record, there is a process that you can go into and have a look at PBS, AIR information and Medicare billing. And then you're able to identify if any of those care plans have been done elsewhere and what date. You won't see the actual plans, but you'll see the billing history.
And on that, a question from the chat has come, would it detect MBS items that were billed by other practices, for example, 721, 723 and 707?
Other than going into the My Health record, or practices can use their Proto to get into HPOS and ask the question if there is a ability to bill that patient, but I don't think that gives you a date, whereas it can be advantageous to use that My Health record. There is a wealth of information there now.
Michelle, it's probably worth pointing out that the default settings in My Health record will not allow you to see the Medicare billing.
So
you
you
actually
actually ticks
have
off.
You
A
have
good
to go
point,
in there
Shruti.
and activate it or ensure you can access it.
Yes.
And that's actually probably the most efficient way of finding that information out.
So when you go into that screen, on the left-hand side down the bottom, you'll see 3 boxes that are defaulted to tick. Take those ticks off, press update, and you'll get that updated information for better access.
The third question is, when not actioning a prompt or alert, are there any medico-legal implications associated with primary sense? This is something that has been asked several times, and thanks so much, Caroline. So the responsibility, it sits with the practice around medication safety. The tool itself is not reporting back or looking for errors, and it is here as a safety quality step to say, hey, maybe think twice about this. I'm just alerting you. It is up to the GP's discretion as per the action that they take.
And just to add to that, it's actually your alert and prompt history is wiped every 24 hours. So there's nothing that's actually linking into best practice or medical director to say that you received a prompt in your progress notes, via primary sense on that day. We do always recommend, if you do have particular questions, to check with your medical indemnity insurer. But yeah, Claudia did cover that pretty well.
And number 4 is, does having primary sense installed or active on the server result in medical director Practisoft best practice or other softwares on the server itself work or slow it down? For example, with checks happening every 2 seconds for medication alerts, there has been extensive testing across multiple environments to ensure that there aren't impacts on slowing the system at your practice. If you are noticing any slowing, however, and you're noticing that your CPU usage is going up, we would definitely encourage you to get in touch with your IT provider, or you can let us know and we can investigate it for you as well. And I covered this in the feedback aspect, but if a GP chooses to submit a comment to Primary Sense, the feedback area, it is not identified, so it is anonymous. However, if you would like to put your details in there, for example, if more information needs to be given, that is totally up to your discretion.
I wonder if the questions, is it de-identified from the patient identification and the GP? So, I mean, there's two bits of feedback, aren't there? There's the feedback, general feedback that you said goes into the National Primary Sense. And then there's the feedback you give or the comment you give within a prompt. So is it de-identified there as well?
I would assume that
There's no identifiable information ever leads to practice. So, sorry, hopefully that's out online as well, but no identifiable information. There's actually a specific extraction process, which we'd be happy to include a bit of a flyer about that process as well. But very good question.
I should add that, sorry, I'm feeling compelled to say this. If you're as impatient as I am and you've provided feedback about something you think needs amendment or improvement, keep in mind that this is a process and the PHN has the feedback information with Primary Sense and it has its own governance. So things take time to change. So, submitting the same information each time may or may not give you desired results. So maybe speak to these ladies instead.
And I think we spoke to question 6 earlier. At the moment, PenCat is not the same as Primary Sense. Primary Sense is not the same as PenCat. The Primary Sense has been built with doctors involved in the process and the developing and input. It is a clinician-led tool where PenCat was a wee bit different. We've already heard that our GPs here are playing with reports, and that's amazing. They're simple enough that they can be used by all of practice staff. And as Tristy mentioned, the team approach, and James has said, is ideal if that's possible in practice. The specific patient groups, at the moment, we're limited to the reports that we have. They still give you good value, but they're not the same as PenCat, nor can they be customised and filtered down exactly the way you could do with PenCat.
Was there anything else from the panel that you would like to add before we conclude the webinar?
I just wanted to follow up on the point. There was a question that went to Pete about whether Primary Sense could be used in a punitive way for practices not meeting certain targets. I think that could be turned around, and Primary Sense gives practice teams a chance to commend each other and themselves. We don't get much appreciation of the great work that all of us in primary care are doing, and this gives us the opportunity to provide that to the people around us that are doing all that work. So I think just there's a positive side to that too.
Absolutely, and there's a really good opportunity, like PQI has been set up as a way of identifying some particular areas of focus, so it's a bit of a guide as well for where practices may want to focus their quality improvement efforts. So that's good points.
Anything else?
So my take home really is just to start small. Just find the one thing that you want to start with, turn off all the other things, and just start small and build up from there. And just talk to your colleagues within your practice about what you're doing, find what they're doing, and together you'll build a picture of what works for your practice.
I'm going to make a slightly different comment, but I appreciate why James felt the need to say what he did. Both of us have previously worked in the UK and understand performance-based payments aren't particularly something that anyone wants to review. So My suggestion is I actually am using the tool to see what proportion of my total patients are. They're more complex patients, because working in general practice, there's an understanding of 80% of your time is probably spent looking after 20% of your patients. So maybe a self-care point is to go back and have a look at those numbers and see whether you're actually practicing sustainably with the numbers that you have, and if not, how can you improve that by way of either individual audits or practice processes, or asking your colleagues for help, and having a more team-based approach to the care of some of those complex patients as well.
I think that's so valuable, just if this gets us working more as a team, I think that makes general practice more sustainable for everyone.
Wonderful, thank you so much. Well, thank you so much, especially to our GP panel for coming here tonight and providing your really valuable insight and experience to the tool thus far. And it's also great to know that our QI&D officers have had a really positive part to play in that as well. I'd like to also thank everyone online for joining us in your engagement this evening. Can I just remind that you will be sent a survey after the completion of this webinar, and we would really appreciate your honest feedback in terms of what we can do for our ongoing webinars that we will be running. And we will be sending out a certificate of attendance for your RSCGP CPD points. Thank you so much for everyone joining us online. Have a lovely evening.